The gastric band became available in the United States in 2001, and over the next 10 to 15 years, about 500,000 bands were placed in patients across the United States. Unfortunately, in the 2010 to 2015 timeframe, we learned that bands don't last, and the failure rate for bands is unfortunately quite high. So since about 2015, bands have rarely been placed anymore in the US. In fact, I stopped placing bands in approximately 2011. So you may be one of many people who carries a gastric band in their abdomen and it's causing problems, or it's simply not working anymore, and the natural question comes up, now what? Well, first of all, I want to make sure you understand that the band failure is not a patient failure, it's a device failure. Bands can fail even when patients are doing all the right things and doing all the right follow-up. It's just that the stomach and the esophagus get tired of having this artificial device on them, and as we'll mention, there are many other ways that the band can fail or cause problems. The second thing I want you to know, and this is my opinion, is that all bands that are still present in patients should be removed at the earliest practical opportunity. Now you're going to ask naturally, how do I come to these opinions, and what's the foundation for my opinions? So first of all, my name is John Pilcher. I'm a bariatric surgeon in San Antonio. I've been doing bariatric surgery since 1995, and so I already had an established gastric bypass practice when bands became available in the US. And I was pleased with the option of having a band. I was among many surgeons who thought that these were going to be a nice additional technique in our bariatric armamentarium. And starting in 2002, about 6 months after the bands came to the US, I started placing gastric bands, and I placed almost 500 in the middle 2000 time frame, trailing off in 2009, 2010, and then, as I mentioned, stopping in 2011. And early in the band experience, I was fortunate to be tapped as an instructor or a proctor for surgeons in the southern US. And I was especially involved and very interested in optimizing the process of band adjustment, especially using X-ray, which is also called fluoroscopy, to see exactly what the band is doing on the stomach and the esophagus during the process of adjustment. And since I was involved in these research projects, I was also very directly involved in the patient care and talking to patients over the years after their bands were placed. And what I saw in my own practice, and what's been replicated across the world now, is that over the first 2 or maybe 4 years, the band can be very useful and very helpful for many patients. But beginning at the 2, maybe 4-year time frame, every year the band starts to cause some new problems in sets of patients. And the band has many different ways it can fail. It can actually have a device complication such as breakage or infection of the band. It can cause damage to the tissues such as erosion, or maybe it's something more gradual and more subtle where it just kind of stops causing that nice sense of restriction, or maybe it starts causing reflux and heartburn or swallowing problems. I have another video on this YouTube channel that describes the modes of band failure in a bit more detail and the problems that are left behind, but suffice it to say that research confirms that 10 years that about 80% of bands have failed or are causing damage of some type. And in this video I want to talk about what happens next. Where do we go with that situation? And to give you some guidance on this question about what to do after the band has failed, I'm going to build both on my personal experience in working with patients and on research that I did in preparation for a talk that I presented to the National Surgeons Meeting in Nashville just this past November of 2018. When I talk to patients about band removal, I also like to offer options about what comes next. Some patients are just done. They just want to have the band out and they want to have a normal stomach and they don't want to think about subsequent interventions, and that can be reasonable. And in fact, many people have changed their eating habits and have a decent chance of keeping their weight down at a lower healthy level for many years to come. Or many people have just felt so sick with the band that they don't care if they gain weight back, at least not right now, and they just really want to have normal eating and feel healthy again after struggling with the band for some time. But on the other hand, it's very reasonable also to talk about a subsequent bariatric surgical intervention, because people who went into the surgical procedure for the band did that because they have a metabolic condition of obesity. And just having the band removed, having the band in place, and that process doesn't eliminate the condition of obesity. And once the band is removed, then it's very likely that they will regain weight over time. And so it's very reasonable to talk about planning a sleeve or a gastric bypass, or in less common cases also a duodenal switch. And the third question that fits in naturally with question number 2, after we've selected what procedure we want to aim for second, do we want to do that procedure at the same time as the band removal, or do we want to have an interval or delay between these? And I'm going to break those questions down in a little bit more detail. Because the duodenal switch has its own set of considerations related to vitamins and absorption and long-term follow-up, I'm going to set that one aside and mainly talk about the balance of sleeve or gastric bypass as a follow-on procedure to a failed band. Now, early on, the surgical consensus was in favor of gastric bypass coming out of a band. That has actually come into greater balance more recently. In other words, the more recent surgical literature shows that the outcomes are favorable for both sleeve and gastric bypass coming from a failed band. My personal preference is a little bit in the direction of gastric bypass because when the band is removed, the band is going to leave behind some permanent changes. So the first thing that we have to think about is actually the esophagus. And it turns out that when a person has had a swallowing restriction for some period of time, years, that the esophagus may be a little bit tired or a little bit weak. And that matters because the sleeve needs a normal, healthy esophagus to swallow easily. The sleeve will let food and fluid go down, but it can also let digestive juices go back up. And if there's any weakness of the esophagus, if there's any major heartburn or reflux, then the sleeve is likely going to allow that to continue afterwards. The other thing that I think is a little bit of a disadvantage for the sleeve, although not an overwhelming disadvantage, has to do with the shape of things when the band is removed. This is actually a pretty decent representation of what actual living stomach tissue looks like when the band is removed, because the removal of the band leaves behind kind of a scar cuff, or we might call it a rind, kind of like an orange peel sort of thing, that's on the stomach. And you can see that the shape is a little bit distorted here. And since the sleeve depends on very clean formation of a narrow uniform tube of stomach, that can be kind of challenging surgically to recreate that tube, breaking down the scar tissue here from the band. And challenging doesn't mean impossible, but challenging does mean a little bit more risk. So that's an additional consideration for the sleeve. Early on, there was a reputation about more leaks from sleeves coming out of a band. I still think it's true that you can have a little bit more leaks coming out of a band whether you do a gastric bypass or you do a sleeve, because this is still a revision operation operating in scar tissue. But my impression from looking at the literature and from my personal experience is that the leak rate is probably the same between gastric bypass and sleeve coming from a band. Now, I will say that one of the things I like better about the gastric bypass is that in the gastric bypass we're able to form our small gastric pouch, not really modified or interfered with from this scar tissue here. We're able to work with the scar tissue or work across the scar tissue in a way, in my experience, that works a little bit more easily than the sleeve. And so there's a sense in which, interestingly, the gastric bypass is easier coming from a band than it is to go from a band to a sleeve. The other thing, as you'll see in my other videos, the gastric bypass is great at treating reflux. And so if you do have a weakened esophagus or if you do have reflux left over from your band, then it's nice to be able to treat that reflux or treat that weakened esophagus using the gastric bypass. The literature says that both of the operations, the sleeve and the gastric bypass, are successful in creating substantial weight loss for people who once had a band. And so as far as I can tell in my own experience in the literature, that is not a big factor. Another weight loss should be successful with both operations. So in summary, if you have a gastric band and it's not working, don't let yourself feel stuck. Know that there are more options. Get connected with a surgical pro in your area and have a good conversation with that surgeon. And then after the band is removed, whether you have another procedure or not, stay engaged with professional medical care to keep your metabolic disease under control going forward.